Welcome to the Mad in America podcast, your source for science, psychiatry, and social justice. Hello, this is James, and welcome to the podcast. And this week, I'm really pleased to get the chance to chat with Dr. Michael Hengartner. Michael is a senior researcher and lecturer at the Zurich University of Applied Sciences in Switzerland. He was an expert evaluator for the European Research Council and the World Health Organization, and currently is a member of the Swiss School of Public Health, the German Society for Social Psychiatry, and the European Public Health Association. His areas of expertise include psychiatric epidemiology, public mental health, evidence-based medicine, and conflicts of interest in psychological and biomedical research. In this interview, we discuss Michael's recently released book entitled Evidence-Biased Antidepressant Prescription, Over-medicalisation, Flawed Research, and Conflicts of Interest. The book addresses the overprescribing of antidepressants, and it critically examines the current scientific evidence on the efficacy and safety of antidepressant drugs. Michael, welcome. Thank you so much for joining me today for the Mad in America podcast. And we're here to talk about your work, and in particular your new book entitled Evidence-Biased Antidepressant Prescription, Over-medicalisation, Flawed Research, and Conflicts of Interest, which was published by Springer in 2021. And first, I want to thank you for writing it, because, this is such a valuable and important area of the mental health industry to write about. And my reflection upon reading the book first was it's very comprehensive. It collects together an awful lot that I think needed to be pulled together in one place. So I can't imagine it was an easy task to do all the research for it. So you kind of start the book yourself by writing about how you got here, which seems like a good place to start to me. So can you tell us a little bit about you and what led to your interest in research work?
Yeah, sure. First of all, thank you for having me and giving me a platform to talk about my book. I really appreciate it. Well, as I write in the book, I was working as a research associate at the Psychiatric University Hospital in Zurich, and we just were doing kind of basic common epidemiological research. And one of my main tasks was, data analysis and all that kind of stuff. So I got really interested a bit more about the scientific process, about the ambiguity of data, and also the sometimes arbitrary decision you make when analyzing data and reporting statistical results. So that was always because I felt that makes me a better researcher. Yeah, and then there was this replication crisis in psychology where seminal studies were found to not replicate in independent evaluations and independent studies. That was really interesting. So I started to look at depression and treatment of depression and all that stuff. And I got really interested in all these biases that were reported, like data dredging, which we also call p-hacking, because of the p value it represents the statistical significance of results. So, and that's when I discovered this whole universe of research done in one of the areas where I was most interested in depression, the epidemiology of depression, which also includes treatment, outcomes, and all that stuff. And I discovered those studies where they clearly showed how selective results from antidepressant trials were reported, how studies with negative results just remained in a file drawer, and then all those questionable or problematic research practices. And that really got me, So that's why I dug a bit deeper into this literature and discovered so many things that were awfully wrong to me. So I started to do more research, and then I also started to write about it. And one of the main areas where this was actually documented and research was in the domain of antidepressants. So that's why actually I became a little bit focused on antidepressants, not because per se I had an intention, I must show the world that the evidence base behind antidepressants is debatable. but because this was one of the best research topics. And that's where I slowly and step by step got into this. And also, you can say, where I got stuck. So, wow.
And I just wondered, Michael, obviously, we'll come on to talk in a bit more detail about some of the issues that you kind of uncovered and wrote about. But, I've talked to other people who, researchers and academics who said they, had a fairly mainstream view of the mental health industry before they got involved in this. They kind of thought we'd got things sorted and we'd got good evidence-based treatments and diagnoses were discrete and all the rest of it. So, were you a person that kind of had that belief before you started writing the book, and did what you find kind of shock you almost?
Yeah, I also had this prevailing view because that's how we were taught and what we were taught, and especially at the clinic where I was working, that was never put into question, because I also learn from my surroundings, and then with talks I have with colleagues who also, did clinical work and all that stuff. So that was actually never an issue that perhaps the drugs work, let's say, at least not as well as the literature might suggest. But that was never, I was actually not aware of this. So for me, it was quite a surprise to see that half of all trials fail to even find an effect. And then to discover that if you look at the literature, you just see almost exclusively, you see just positive trials. And so for me, that was also quite shocking. And because I knew that this knowledge was either not present or perhaps also a bit ignored. In my view, most people were simply not aware, which I discovered later after I did publish my first papers, and then during discussions with colleagues that for them it was also quite shocking, because for them it was also a moment where they had to realize, okay, I was always so convinced that they work miracles, or perhaps not miracles, but they are really essential, and they work so well, and then you discover those studies who demonstrate that at best the effect is rather small and of questionable value. So that was very surprising to me as well. Yeah.
And also, in the kind of introductory section of the book, I was really interested to read that, you do share some personal experiences too, and you do describe a time where you experienced what you call pervasive and profound sadness. So I wondered if you wouldn't mind sharing a little bit about that and what your thoughts were about that at the time.
That was a very difficult time because I just finished my college. So I was 18, 19. So, and then in Switzerland, where we have a mandatory military service. So I had to go there. And that's what for me was terrible, because I never wanted to go there and play soldier and shooting around and being yelled at from morning till evening and not sleeping, and just absolutely not a military man. In the army, my mood got worse and worse, and there was also a lot of bullying, because I expressed clearly also towards my officers or whatever that I'm actually not a pro-military guy. So you can say they hated me, and it was also a difficult time because I had a breakup shortly before I went into the army, and then all those things came up, and that's the time when you the transition from adolescence to young adulthood. So it's always very messy, and you ask yourself, who am I, where am I, what is my future? And today you would say I was getting depressed. Yeah.
It sounds like you thought that was, a situational thing, and you recognize that there were things that were happening around you that made you, or gave you a tendency to feel sad and lonely and all the other things. But, did you consider that you might be depressed, or, was that not something that occurred to you?
To me, it was clear that I was not feeling and behaving like I usually do. So for me, it was clear that I never experienced such a lengthy time of unhappiness, and so for me it was quite clear that I'm feeling depressed. But for me it was also quite clear that this is due to the situation I was in, and it was a consequence of being in a difficult place at a difficult time with it. It was also what I experienced near the end of my military service. So knowing that, okay, it's over in 2 weeks or 3 weeks. So I immediately felt a new growing, optimism, and my mood was improving then quite rapidly near the end of this military service. Yeah. So for me, it was quite clear that it was situational and due to the circumstances. Yeah.
Thank you for sharing that. Well, I'm glad that didn't last too long, and I'm glad that you found a way out of that. So, if we kind of move on to look at some of the things that we interested me reading the book. So the first part of the book is about kind of using antidepressants in clinical practice, and I'm sure that people will go off and read it for themselves, but there's a very clear kind of thread in the book that the evidence for using antidepressants in mild to moderate depression is really very poor, and we've seen some recognition of that in the UK, particularly because our kind of evidence body, the National Institute of Clinical and Healthcare Excellence, has stopped from recommending antidepressants as a first line treatment for mild to moderate depression, but we quite often hear spoken quite loudly, actually, that antidepressants work better and have more utility in what's called severe depressive episodes. So I wondered if that was something that was supported by the evidence or trials or real-world use when you looked at it.
So that's one of the biggest conundrums, I would say, or not a conundrum, but unanswered questions, because there is no unequivocal evidence or conclusive evidence that they clearly work better, because the scientific literature is quite mixed. Most large-scale individual patient data analysis actually do not find that the treatment effect is larger in what we call severe depression than it is in mild to moderate depression. A few analyses did. One was very influential by Fournier and colleagues, published in the Journal of the American Medical Association in 2010, but that was based on a very small sample, 700 people around, something like that. And much larger studies that used individual patient data with several thousands of patients actually were not able to replicate that the efficacy increases massively in severe depression. So I would say, based on this literature, there is scant or at least very insufficient evidence for the claim that they clearly work better in severe depression. But the issue is more complicated, because in the end, what is severe depression? And the distinction between mild, moderate, or severe depression usually is made simply based on those rating scales, like the Hamilton Depression Rating Scale, which actually gives equal weight to all items. So it's just, if you have a score, let's say 24, you are considered moderately severely depressed. If it's less than 16, it's mild depression. So you get the point. But that is very problematic, because imagine that someone reports mostly sleep problems, appetite issues, problems concentrating, all that kind of stuff, and the person has a score of 24. Another person has severe anhedonia, so lack of interest and pleasure, severe psychomotor retardation, suicidal ideation, but has the same score of 24, because the person has, let's say, no sleep problems, no appetite changes, whatever. So it has the same score. So people would say they have the same severity, which actually is quite absurd, because there are clearly symptoms that are more indicative of a severe disorder episode, like especially suicidal ideation and behavior, and also psychomotor retardation, which are clear indicators of a more severe episode. So this is also that's the problem. If we only categorize into mild, moderate, severe based on these scores, we come up with findings that actually lack or are insufficient validity. And then another issue is all people firmly excluded from such efficacy trials. The trials usually exclude people with which are acutely suicidal. They exclude people who have psychotic symptoms. They exclude people who abuse substances, and they also exclude people with comorbid disorders, mental and physical. And usually these are the people with truly severe episodes. So they are basically excluded. So what we call severe depression in those trials in the end, it's very debatable whether that really is severe depression. And those who probably really have severe depression, those with multitude of comorbidity and acute suicidality, psychotic symptoms and all that, personality disorders, these are excluded. So in the end, we don't really know how the drugs were in these, let's say, more truly or more genuinely severely depressed people. That's just a big question because these people are usually not included in such studies. So that's why I say it remains to be answered whether the drugs really work better in severe depression. But based on the evidence available, we can't draw firm conclusions.
Yeah, that's really helpful. Thank you. You know, the kind of subjective nature of rating scales is quite a big issue, isn't it? And you can see why academic psychiatry has spent such a long time looking for biomarkers and, you know, some more tangible measure of what a disorder may or may not be. But they haven't made that much progress, have they? So you'll get the same rating tool like the Hamilton scale, and it could be applied by 3 different psychiatrists, and you could get a different diagnosis or outcome from each of those 3 people.
Yeah, right. And scores, what you also need to be aware, I don't know whether this is mentioned in the book, but they include preferably people with high baseline scores, because the expectation was that you know, if of course people who have low baseline scores, so it's very hard to find a treatment effect because whatever you do, it's low, so it can't get any lower. So the aim was to have more positive trials, or the hope was that you have to include people with high baseline scores. So the recruiting centers were under pressure to sometimes also inflate scores, because let's say if the inclusion criteria was a score of at least 24, and then the application of the Hamilton rating scale gave a score of 22. Sometimes it was just, okay, just add up 1 or 2 points and then it's 24 and we can include the patient. So there is for sure also some people where scores were inflated. That's why also, and that's the whole thing about regression to the mean, whatever you do. And if you reassess these people after 2-3 weeks, you see sometimes a really remarkable decline in symptoms, which presumably don't even reflect their true improvements because scores were, you know, inflated at baseline. So you eventually see a decline that actually does not reflect a true improvement in the illness, actually, or disorder, whatever you want to call it.
Yeah, that's hugely important, isn't it? And kind of linked in the book really, really nicely too. You talk about the transformation of the concept of depression between the 1970s and the 2000s. And I wonder if, you know, we, not just us as kind of medical consumers, if you like, but perhaps doctors too, have been conditioned to think of depression in a different way, as not an episodic thing, but a chronic thing. So in the 1970s, you write that depression was characterized as a rare but severe disorder that almost always improved with little to no intervention. And yet now, of course, you know, we see depression and anxiety known as highly prevalent, called a global crisis. And, you know, people, I think, are sometimes quite surprised when you say it's not a chronic or ongoing condition. Many people improve without any really aggressive treatment or intervention. So, you know, I wondered what you found when you were kind of writing about how we conceive of depression now compared to, you know, in the 1960s and 70s.
I think it's important to stress that's not just my take or my reading of the literature. That's why I painfully cite experts in psychopharmacology and those considered the most powerful or most important or most eminent experts in this domain, which clearly stated that in most cases it's episodic. Whatever you do, also without treatment, most people will improve. And I quote these people, but otherwise people will say, well, that's Hengartner has a very odd reading of the literature. So that was actually the common view until the early 70s. And then things started to change. But I think the most important driver was that the new approach to depression was, the idea was we need a unified symptom-based definition and diagnosis of depression. And that's also when also organization like the World Health Organization started to apply symptom questionnaires to larger population and suddenly reported, 10 or 20% or whatever of people have depression symptoms. But that crucial thing is, what are depression symptoms? So because depression has more clearly specific or what we call also core symptoms of depression, like really low mood, anhedonia, those things. And then you have many other symptoms that are completely unspecific. Of course, people with depression often have those symptoms, but most people who have those symptoms don't have depression, like appetite change, sleep difficulties, problems concentrating, tiredness. So these are very common, what we also call stress symptoms. And can also be symptoms of physical medical condition or due to another medical treatment. So these are very unspecific. And once they started to apply those symptom-based scales, of course, they came up with sometimes quite high symptom scores. But if you would look at what symptoms or which kind of symptoms are mostly responsible for those high depression scores, you would see that exactly these are sleep problems, appetite changes, problems concentrating, and all that kind of stuff. And these people who are like more constantly in an environment or in a situation that people who have high workload or job strain or constant relationship problems, marital issues, all that kind of stuff. Or even if you have a newborn. So I have 3 little kids. For 6 years, wasn't really able to sleep. So I had for months and years, I had sleep problems. And of course, because I was always so tired, I had problems concentrating. And sometimes I also lacked appetite, because if you are so tired and all that stuff, usually you're not very hungry. So if during this period, where actually I was one of the happiest men in the world, because I had these little kids and they are so gorgeous, but if you would apply a depression scale, it would result in, oh, you have mild depression because you have sleep problems, you have this and that, and you're tired and whatever, And this approach, which finally also culminated in this new major depression diagnosis, which now was made fully based on symptoms, massively increased, of course, the prevalence rate. And the thing is even worse with depression questionnaires, because at least with the diagnostic criteria, you require that 1 or 2 of the core symptoms must be present. But the depression questionnaires, you can basically indicate that you have no low mood, no anhedonia, but just sleep problems, all that stuff. But the questioner completely ignores this. He just makes a sum score, and if you have sleep problems and all that stuff, he gives you a score which indicates, oh, you have mild depression. So, and that was this big move towards this symptom-based approach. It was also heavily, of course, supported by the pharmaceutical industry, which also advertised to GPs that they must always be on the lookout for masked depression, because there are many patients, they don't clearly present with low mood or anhedonia, but it may be appetite change, sleep problems. So that's masked depression. That's why we need to assess those symptoms. And the message, put simply, was as soon as someone has increased scores on these depression scales, that's probably depression, even if you don't feel that the person is depressed, has depressed mood. So this will briefly, that was a little bit what was going on during the 70s and the 80s, and then which led to a complete change in how prevalent depression is and how persistent it is. So put simply, that's a very brief summary, but that's some of the most important developments that actually changed the whole definition and then also the whole perception of depression during this crucial time.
There's a kind of theme in the book, isn't there, about the pharmaceutical manufacturers meddling in or getting heavily involved in the mental health business, if you like, and that period, the kind of 70s and early 80s and even into the 90s, were characterized by active campaigning, weren't they, by the pharmaceutical manufacturers to redefine depression and anxiety, to aggressively treat it. The chemical imbalance theory arose, and it was started to be seen as a very disabling but very treatable chronic condition that people might have to take drugs for life for. So the concept changed because it was pushed that way to an extent, didn't it?
Yeah, and it was pushed. Of course, it was pushed from the pharmaceutical industry, but there was really also true concern within or among psychiatrists and psychiatric associations that we are missing a terrible issue here, because if we don't look out for those symptoms, we miss so many depressed cases. And probably during the 16 and 70s, there were most certainly the prevalence rate were mostly so low that probably there were people with depression who were not correctly detected and diagnosed. But the situation we have now is actually completely different. Now we have overdiagnosis is one of the biggest issue, because as soon as you present to a GP with all kind of not even specific depression symptoms, you get a diagnosis, sometimes prematurely, and sometimes it's really also a false positive diagnosis. So now we have rather, because the whole campaigning and these awareness campaigns that also followed, which came then in the late 80s, and they specifically addressed the public and the GPs, because, hey, you miss so many depressed cases, you have to look out for also for the unspecific depression symptoms, like the stress symptoms, because otherwise you miss so many depressed cases and we must treat them, otherwise they have chronic depression, whatever. Although there is absolutely no evidence that if you treat people with mild depression that they have a better outcome. Now, in fact, there are studies who clearly show, regardless of whether GPs detect depression or not and whether they treat it or not, the outcome actually after 1 year is almost the same. So it actually did not even make a difference whether they detect those mild or sub-threshold cases or not. But the message was clear: you have to diagnose more, you have to treat more, you have to prescribe more drugs. And of course, that was very welcome also for the pharmaceutical industry. But it was not just the industry who pushed towards this new narrative, and it was also a deep fear from within psychiatry that they are underserving so many people.
Yeah, as we mentioned, that the kind of pharmaceutical manufacturers' approach to this whole area is quite a theme too in the book, and there's a whole section on flaws in antidepressant research, which again I recommend people read, because it's comprehensive, it's very well referenced, but the kind of tricks and game playing that kind of goes on in research is, to the person like me who's not that familiar with it, is quite eye-opening, and even the way that drugs are licensed. So you write about the way that drugs are licensed by regulators such as the FDA in the US and MHRA in the UK, and I suppose I had this conception that, before a drug is granted, it goes through many, many years of trials with hundreds and hundreds of thousands of participants, and there are many, many positive trials that show a clear benefit. So it's pretty surprising to find that actually only 2 positive trials are required to license a drug, and sometimes not even 2. And the most positive ones are selected, and then many are not selected. So I wondered if we could talk a little bit about your views and what your research told you about the way that drugs are licensed and whether we should be concerned about it.
Yeah, that was for me a very important topic, because early on, one of the most frequent responses that I received when I submitted critical articles about questionable evidence-based behind or supporting efficacy was that this is actually, the whole discussion is mute, because the drug regulators would not have approved the drugs if they were not clearly working and if the effects were practically or clinically meaningful. And that is, I heard this argument even from very well-known psychiatry professors, and that obviously revealed that those people apparently are not really aware how the agencies, the drug agencies, license drugs, the whole process. So that's why I meticulously dissect and then also detail how it happens. And as you said, the standard for drug approval is put very low. Put shortly, if you can't beat a placebo pill in 1 or usually 2 trials, but for some drugs it was actually just 1 trial with clear statistical evidence that the drug was better than placebo, you get your license, regardless of whether only 2 of 5 or 2 of 6 trials. So there can be a majority of trials who were negative. And in the other twos, there was a marginally small difference between placebo and the drug, but it was statistically significant, and that was enough. Because I quote a lot from the FDA, which is considered the most important drug regulator agency, that they made clear that they are just looking at whether there is statistical evidence for an effect and not whether this effect has a practical relevance. So they made clear that if this effect is statistically significant, no matter how small, just 1 or 2 points on a Hamilton scale, they consider it as evidence that the drug has demonstrated efficacy. Because in the end, it was statistically better than a placebo, but if you look at the magnitude of this difference, you'll discover that this is a very, very small difference. But that was enough to license the drug.
We talked earlier about the Hamilton Depression Rating Scale, which I think is 30-something points.
But they got several versions. You have the Hamilton 70 items, 19 items, 21 items. But the most widely applied measure, the Hamilton 17 item version, you can get from 0 to 52 points.
And yet the drug placebo difference was something like 2 points.
Yeah, or even less in more recent analysis. So sometimes it's more around 1.7, 1.8 on a scale from 0 to 52. Yeah.
And as a kind of healthcare consumer, I don't like that term, but I haven't found anything better. As a healthcare consumer, when you read that this drug is effective, you kind of imagine, perhaps somewhat naively, that effectiveness is large or very, very significant. But when you actually dig into the details, such as written in your book, and you find out that the drug placebo differences are so tiny, and that's even given that the cards have already been stacked in favor of the trial drug by so many other ways of reporting the data, that's quite staggering, I think.
Yeah, right. And right. You always have to consider that this difference presumably, or some might say likely, is even inflated due assumptions that the models made, how they deal with missing data. There's actually quite clear evidence that the statistical approach to data analysis, with the last observation carried forward, which should account for people who drop out, who don't provide an end score, that this leads to an inflation of differences. There is actually, the FDA has conducted his own analysis, and they show that this inflates the false positive rate. And almost all drugs were approved based on this intention to treat with last observation carried forward method. I don't want to go into details, but it's a little bit statistical, and I try to explain it a bit in the book. But in essence, what people need to know is that we can't even be sure that the true effect really is 2 points. Perhaps it's even smaller than that because of the biases we know that are there that tend to rather inflate differences, overestimate differences between drug and placebo. And there are also other factors like using a per protocol analysis instead of an intention to treat analysis. Sometimes also certain centers were excluded because the data didn't look quite good enough in those centers. So you restrict the study population to, let's say, selective population where there seems to be a bigger effect. So you don't report the results for all, and some more and some more. So there are really systematic biases that suggest that perhaps this small difference is even an overestimate.
Yeah, absolutely. So, again, people can kind of read for themselves in the book, and I think they should, because you lay really clearly out how these problems kind of in research kind of stack on top of each other and become additive, and then there's a presumption to approve drugs by the regulator. So, you've talked about some of them: selective publishing, short-term trials, changing statistical methods halfway through, inadequate sampling, ghostwriting. So, given all this, I wondered what you felt was perhaps the biggest driver of distortion in the evidence base supporting the use of antidepressants.
Biggest single factor in my view certainly is selective reporting, which also includes publication bias. So we know quite for sure that just about half of trials are positive, but in the published literature, this rate is close to 100%. Not exactly, but which, if you just look at the literature, you have the impression that in most trials, efficacy was demonstrated when in fact it's really not. It's just in about half of trials, which actually is already quite worrisome if a drug just works in every second trial. But selective reporting also excludes also selectively only reporting outcomes that were favorable, because even if the main outcome, the primary outcome is the Hamilton depression scale, you can use that scale in very different ways. You can calculate, you can dichotomize, you make arbitrary categories between people who have improved or not improved. You can use different statistical modeling approaches to whatever you look at endpoint scores or change from baseline. Then you can also use combination of criteria, which was done. So, for instance, people have a depression score lower than that, and based on another assessment, they were considered as responders. And you can combine so many different, so at least just with one scale, you have plenty of different outcomes that you can define. So, and that's what also happened in the infamous study 329, the paroxetine trial, where they started to that was just about p-hacking in creating new outcome based on scales they had, or just reporting new scales that they were not eventually declared as primary outcomes, and so on. So there are many things, and that also falls into the rubric of selective reporting. And in the end, if you have 2 or 3 different depression scales, which usually they have, then you have some global scales of improvement, like the clinical global impression. You have also, sometimes you have a scale for global functioning, you have a scale for quality of life. And if you have so many different outcomes, and you can define the outcome in many different ways. So in the end, you have 20, 30, 40, 50 different ways how you could define your outcome. And once, even if the trial was negative on the pre-specified primary outcome, you start digging into the data and you start transforming and changing and everything, and you will inevitably come out with some kind of definition of outcome where you can demonstrate a statistically significant effect. But that's just post hoc changing, which is actually very, very mostly just randomness that you capture, so false positive findings, but that happens a lot. So besides of selectively publishing the trials, those who are published are also selectively reported, often, not all, but there's a lot of selective reporting going on. So
I think it all highlights, again, how difficult it is for people to make an informed assessment about whether antidepressant treatment is right for them and whether the drug is efficacious enough to really make a difference for them. And it seems to be trial and error on the basis of the person, rather than being able to rely on a consistent, reliable evidence base to support your decision about whether to take them or not.
True. And then again, there's the other issue that we talked about in the beginning, that even if we could say we have a clear, robust effect, perhaps regarding activation, you have still no guarantee that you will really improve from this effect or benefit from this effect, because as we said, and then there are many surveys, user surveys, where this is made clear that for some this effect was helpful, for others it was perhaps for a short time it was helpful, but then with time it became kind of a burden or became turned into an adverse effect. And for some, it's right from the beginning, it was an unpleasant, rather an adverse effect. So even if we had clear and robust, reliable evidence that this is where the drugs really make a difference, we still, on an individual user level, we can't be sure that you will really benefit from this effect.
Thank you. I wonder if we could turn to the kind of latter sections of the book, which talks about solutions for reform, and also again captures some of your experience of having written critically about these issues. So you share how difficult it is to give messages that contradict this mainstream narrative, and you wrote that there were times I felt exhausted and crestfallen, demoralized by insults on social media and irritating ad hominem attacks by anonymous reviewers. And as someone looking into this world who's not an academic, to me there seems to be a real pressure to protect the reputation of antidepressants as safe and effective drugs by key opinion leaders, senior voices perhaps in psychiatry. So, I wondered if you felt that too. And, I wondered what it was like actually, writing a book from a critical perspective like this, because I know it will be welcomed, but I know it will also be challenging too.
Yeah, that's why I hesitated for a long time, because as I describe in the book, at the beginning I was very naive and I thought, oh, okay, this is an interesting scientific analysis of the evidence base, but I quite quickly realized that it's more than just about the science behind effectiveness. So there are a lot of different interests here that sometimes provoked very, very angry responses. And, as a practitioner, you always need to consider how these people were trained. They are not aware of those studies, that the over 1,000 studies that I reference in my book. Because when I talked at clinics or hospitals, and the audience mostly is very receptive, and I had great talks after the presentations when psychiatrists and other physicians came to me to say, oh, wow, that's really news to me. I never knew about all those studies, for instance, regarding selective publication, all that stuff. And they were also quite shocked. So I don't think that the majority of practitioners, they just try to defend something that the pharmaceutical industry wants to prevent. They are really convinced that the drugs work. And what makes things even more difficult is they observe it in their daily practice. And as we discussed before, what they observe, in most cases, they observe improvement, but because they prescribe drugs to most people that they see, they can't really judge whether this is a drug effect or if it would have occurred even without a drug. So, but they see improvements. They were trained that the drugs are effective. They often go to continuing medical education programs that are often sponsored or otherwise supported by the pharmaceutical industry, with catchy key opinion leader giving marketing messages, and so that's actually the whole universe. And suddenly there come some strange people along who challenge this worldview, this belief system, and so that's why I was also called a flat Earth believer. That was one of the nicer ad hominem attacks, because for them it's just completely absurd that. No, it's so clear. There's so much evidence. We were trained in medical school that this works, and then we have those presentations and we have those educational events, and we see it. And then suddenly comes someone and says the treatment effect is sometimes quite uncertain, and they just can't believe it. And I think that's actually the most people are simply not aware of these issues, and for them it's just unimaginable that it could be quite different to what they were trained and taught and what they observe. So I think that's the main issue. And then the critical appraisal of scientific data is not a crucial thing in med schools. Most doctors are poorly trained in science and data analysis and statistics, so they don't really most don't really understand it. And they don't see, for them it's just, but it was a statistically significant effect, so end of the discussion. So they don't see that methods are much more complicated than that. And they don't want to denigrate the scientific knowledge of doctors, but most doctors, of course, their training is about practice and not about science, and that's a known issue. So they rely on what their supervisors tell them, or the people who present at such lectures or medical education events, and also the visits from pharmaceutical sales representatives, which also mostly deliver marketing messages.
So, when you were thinking about, reform and the future, I wondered what you felt was perhaps the biggest change that we could make to this whole area, so that we could try and ensure that more people are helped and less people are exposed to potential harm. What could we do differently?
Yeah, there are different approaches. I think first and foremost, we need to change the way how we define and diagnose depression. So I'll make a suggestion that we make the definition more conservative. So to exclude more reactive, normal emotional reactions to stressful life events. And so we need more stringent definition that sets the bar a little bit higher, because now the diagnosis is so over-inclusive. Just 2 weeks of feeling down or for whatever reason qualifies as a major depression episode. Even the term major, because that's one of the most ridiculous things. You can have major mild depression, which is contradictory. Well, what is it now? Is it mild depression? But major sounds like a terrible illness. But actually you have major mild depression. So we need a different definition. And then, of course, I think one of the most important factors is that the whole drug licensing approach needs to be also more stringent, and just beating a placebo pill in 1 or 2 trials is just not enough. So I think a new drug should clearly demonstrate that it is better than established cheap drugs, standard drugs that are already for years on the market. So a new drug should demonstrate that it doesn't beat a sugar pill. It should demonstrate that it beats an established treatment. Otherwise, it has no added value when it comes with a similar adverse effect profile. So that's another thing. And also that you can conduct as many trials as you want. You just need to show that at least 2 were positive. Also, it's a very strange approach. As a penalty shooter, in football, if I hit the goal just every 10th time or every 8th, that doesn't make me a good penalty shooter. Even I can say, hey, from 10 shots, 2 were successful, or so, hey, you're a good penalty shooter. If I just hit 20%, that's a very poor rate. So I think that should take into consideration. I think the majority of trials clearly need to be positive. And then, of course, improving pre-registration, clear adherence to a study protocol, so to minimize the whole effect of selective reporting and all that stuff. And what we clearly need is a rather strict separation between industry interests and medical practice. So industry funding of continuing medical education and the sometimes massive financial support of department chairs and whole medical department that make most of their income due to pharmaceutical money. We need a clearer separation, because otherwise, of course, if you know who pays for your job and who pays for your research, of course you are responsible to that person. You also need to deliver, because the person who pays expects something in return. So scientists will, even if it's unconscious, they will try to present the results that satisfy the paymasters. So we need a clearer separation here as well. So we actually need to end the massive entanglement between clinical practice and pharmaceutical financial interests of the pharmaceutical industry. That needs more separation.
And I wanted to ask, as we come towards the close, I wanted to ask about you. You recently shared on social media that in addition to being a researcher, you were starting to train as a psychological therapist. And it's such welcome news, Michael, because we need so many more, I think. So can you tell us a little about your decision to become a clinician as well as a researcher?
Yeah, there are different reasons. For me, it's also about, development and having a new perspective, something, doing more than just research, which sometimes can be rewarding, but most of the time can also be very frustrating and a very difficult process. In doing all this kind of research, I was always wondering, is there not another way you could do more, perhaps? Also doing something different besides just sitting in front of a computer and writing papers, analyzing data, searching the literature and all that stuff, which is very interesting. But sometimes after a few years, and depending on the reactions that your research provokes, it can also be quite challenging. So therefore, I came to the decision that I also want to go into clinical practice, be closer to really those directly trying to help people, because science is very indirect, and whether there really is a transfer from science into practice is also a huge unknown. Whether my research really changes something, who knows? And if it does, perhaps it's just a tiny little bit. So to do more, I also need to work in practice, and I'm directly trying to help people with what I can offer. So that would be psychotherapy, since I'm not a physician.
Michael, thank you. It's been a pleasure to talk today. And, I have to say your book is highly readable. It's compelling and it's comprehensive. And, it's pretty clear from the 84 pages of references, quite how much research effort went into putting together this picture of, I have to say, my personal opinion, I know, but a pretty dismally broken system that an awful lot of people rely on to help them get out of some very difficult places. So, I hope that your book does open that critical conversation up to, many more people, and allows us to interact with each other with a bit more civility about how we improve, because improvement is desperately needed. And I'm so grateful to you for joining me today, and also for your efforts writing the book.
Thank you very much, James. It was a great pleasure for me talking to you.
Well, I just want to thank Michael so much for taking the time to talk with me today for the podcast. And if you'd like to know more about the book, you can visit the website link.springer.com and search on Michael's name or the title Evidence-Biased Antidepressant Prescription to find the book. So, as always, thank you for listening, and until next time, take care. Thank you for listening to the Mad in America podcast. Visit madinamerica.com for more news, views, and updates.